Hello, I am Renato Ambrosio from Rio de Janeiro, Brazil. I'm very happy and grateful to participate in this International Keratoconus and Corneal Cross-Linking Summit 2023 meeting from Shanghai, China. I am here in Brazil, in Rio de Janeiro, and my talk is related to advances in diagnosis for keratoconus and ectatic corneal diseases. I am the current president of the International Society of Refractive Surgery, which is an organization that holds the opportunity to provide and educate on excellence in refractive surgery. So I invite all of you to collaborate and participate in this great organization. I'm also the president of the Refractive Surgery Alliance, and I'm very grateful for inviting all of you to collaborate with those two entities. We really promote excellence and give value for anyone who is interested in doing the best for the patients, learning the new technologies, and sharing their ideas, their experience, their knowledge, so that we can learn from each other. I do have some financial disclosures, including Oculus, with which I have collaborated for over 15 years. Interestingly, when we think about advances in diagnosis for ectasia, we have to understand the whats and the whys. What we are trying to achieve when we screen for ectasia risk prior to laser vision correction, and also refractive surgery in general, including phakic IOLs and refractive cataract surgery. We are not doing the same when we do that than when we manage patients with corneal ectasia prior to keratoplasty. We have breaking paradigm when we consider that the transplant was the only procedure, and a penetrating keratoplasty was the only procedure that we were able to help patients with bad vision and contact lens intolerance about 20 years ago. Now we have cross-linking, corneal rings, phakic IOLs, corneal ablations, many combinations of these procedures, and we have to understand why and how and when we need these procedures and which procedure will best suit the patient. So we have a new subspecialty, and this is related to many options, and we have to be cautious. And I like this algorithm that I created, A2I squared, which is ancient or philosophical intelligence related to artificial intelligence, and applying both of that. So we understand ectasia susceptibility is not going to be the same as diagnosing, staging, prognosing, classifying ectasia, follow-up for progression, and we need to do that objectively in the best way as possible, instead of using the data subjectively. For example, when we talk about types of ectasia, we have pellucid marginal degeneration. The thinning pattern is different than keratoconus, which is also different than keratoglobus with a global thinning pattern. Here we have an inferior thinning pattern that you can see in the cartoon, and also in Scheimpflug in OCTs, and also keratoglobus. Those are different and more rare situations of corneal ectasia, and you have to be keen on the classification because the prognosis and the management can be very different. When we think about diagnostics for keratoconus, we talk about Pentacam, in which you have true tomography with corneal elevation front and back, thickness mapping, corneal astigmatism characterization, densitometry, anterior chamber evaluation, and also lens opacity understanding. But we now have multimodal imaging with axial length and ocular wavefront, and this has been the celebration for the 20 years of the Pentacam in 2022. The Pentacam will give you indices for looking at different things, even beyond keratoconus diagnosis, like anterior chamber angle closure risk and cataract. But when we talk about diagnosis, we have to see how the patient is fitting in these histograms, considering disease and normality, and disease would change according to which the relevance of each of the parameters. When we talk about keratoconus, we talk about front surface curvature, elevation, thickness profile, and this can be combined in the Bell-Ambrose enhanced ectasia display, in which you have front and back elevation and thickness profile together, and the BAD, which is an algorithm related to artificial intelligence, but I would say the first generation of artificial intelligence, which use linear regression analysis. Michael Belling also had a very nice contribution for the threshold for progression on the front and back surface, on the thickness, at the thinnest point, and on distance correct vision. So if you see, this is the indications for a statistically higher value from comparing to the first exam, and this can be very helpful for objectively analyzing progression in ectasia. When we talk about keratoconus and ectasia, we talk about a paradigm shift which is related to refractive surgery. If you see, the number of publications increased dramatically in the 80s to the 90s, and now we have a huge exponential increase. And this is related to refractive surgery, mainly related to the technologies for screening patients at risk for ectasia, like post-LASIK ectasia, in which you have over 20 years of a conundrum, because we have cases with no risk factors that develop ectasia or no identifiable risk factors. And also we have patients with many risk factors that they are still stable after high myopia LASIK, for example. So we need to be specific and sensitive to identify and stratify ectasia risk. The first publications of ectasia were from Professor Seiler in 1998. He first described 3 cases of progressive stiffening after LASIK for high myopia. A few months later, he developed he saw a case with form-fused keratoconus, defined as form-fused based on front surface curvature, and these patients would have iatrogenic ectasia due to the cornea that was weak before surgery here, because the cornea was weakened by the surgery. And those 2 cases allude perfectly to the pathophysiology of ectasia, which is about mechanical decompensation of the cornea. We have corneal resistance, the innate properties, and the impact from the environment. And this would be very interestingly described by Cynthia Roberts and B.J. Dupes in the cycle of biomechanical decompensation. And any case can be related to ectasia. I would say that any cornea may undergo ectasia if there is enough eye rubbing or enough weakening by the laser vision correction. And it's important that we understand that for avoiding ectasia, for preventing ectasia, the first thing is telling patients not to rub the eye. This is one of the major messages that we have in our violation campaign. It goes beyond that because we want to educate the patient. We know that the patient suffers with the disease, and the lack of information may make the patient suffer even more than the disease itself. We also have to be keen on understanding that eye rubbing can aggravate keratoconus, not only eye rubbing, but scratching the eye in any way, leaping over the eye. It aggravates the disease and even can cause ectasia. And I would say that keratoconus is an ectasia, but many cases of ectasia are not related to a genetic pattern of keratoconus, and eventually are still scratching the surface of those concepts that will have more information in the future. Corneal topography is very important. This was a very important paper that I published in 2003, in which we look at the population that had presented for candidates for refractive surgery, for LASIK and PRK in Seattle, Washington in the early 2000s. And we have about 1% of cases that presented as candidates for laser vision correction with mild forms of ectasia. And these cases can be detected on topography. And you have here 2015 distance correct, 2020 minus, 2025 plus. All these cases would be considered as subclinical or very mild, and eventually the nomenclature for FRUST. But we have to understand that when we screen for cases that are at higher risk for ectasia, we can consider the cornea and also consider the impact from surgery. And the term going beyond but not over is very important, because we are going beyond, not over, the detection of mild forms of keratoconus, and also beyond the front surface topography. And what we are trying to achieve is the understanding of ectasia susceptibility, and enhance the screening for ectasia risk relates to the susceptibility of the cornea to undergo the biomechanical decompensation. And the main question is not only if the patient has keratoconus, but if the patient can be weakened in terms of the corneal procedure for the laser vision correction procedure that the patient needs, and eventually have a low risk for biomechanical decompensation. This is a very interesting case. In 2008, the patient had a thin flap, a subbulbar keratomylosis, a thin flap LASIK, residual stromal bed reasonably higher than 300, PTA lower than 0.4. The patient developed ectasia. And if you look at the topography here with the Steve Kleiss scale, you have a little yellow here. This patient was part of the study that looked at the variability of subjective classifications of ectasia based on corneal front surface curvature maps. We have a variation from 0 to 3 with a mode of 0 with the first scale. Changing the scale, we still have a variation that had a mode of 0, but varying a little more if you have a normative scale. So we need to be objective. And interestingly, this case had the Pentacam data pre-op, so that the U12 files could be analyzed, that we can get a D-score higher than 1.6. And this was also related to the artmax lower than 400. And those will be like the reasonable values for thresholds that I would indicate, but we have to understand that those values can be much better than topography, but they are not close to be anything perfect. This is important to see that SMILE has a low biomechanical impact, but still weakens the cornea. This is a patient that had an abnormal tomography prior to surgery, but I would elude the front surface curvature map. This was published as a letter on ectasia susceptibility with some colleagues, and you see that the pattern of KC1 was indicated in the right eye, even though the Kmax was lower than 45. So this is inferior stippling with irregularity in a patient that had a pattern of keratoconus, even though the Kmax was higher, not higher than 45. So this is a low K keratoconus, which is a very interesting pattern that had many abnormalities detected on many different parameters, front surface elevation, curvature, and thickness profile, and the Ds. So this is a low K keratoconus. When we look at studies, like in this one that we had 105 ectasia cases with the pre-op data compared to ectasia, non-ectasia LASIK cases where post-op is stable for more than 2 years. So we have an expressive population that we can really see the need for improvement considering front surface topography, the IS value absolute, the bad D, and we can do better than the bad D. The bad D had a sensitivity of 60%, around 6. You can shift a little bit and get up to 65%. But the Pentacam random forest, very nice work by Bernardo Lopez using artificial intelligence. We were able to improve it. But we see cases down here eventually are related to the impact from surgery, but they allude to the point that we need to go beyond tomography using segmental tomography, OCT, and high-frequency ultrasound, so that we can see the thinning of the epithelium over the cone. Very nice work pioneered by Dan Brainstein in the early 90s for looking at epithelial thickness that now we get popularized by the OCT. Nice work by David Huang and his lab with Yan Li that we can do segmental analysis based on the OCT so that we can get thickness mapping of the epithelium. Interestingly, can differentiate a true keratoconus with a thinning pattern than a pattern of thickening of the epithelium that is related to corneal warpage due to contact lens. So it's interesting that we can look at more data. And we have here a very good example of a patient with mapped dot fingerprints. You see the stippling on Scheimpflug on curvature from Placido, and you see the thickening of the epithelium and how easy it is to remove this epithelium that has classic evaluation of mapped dot fingerprints. So, and the bad D here is a little yellow, but I would say this is not ectasia. Interestingly, this patient do very well with surface ablation. Going beyond tomography, we have corneal biomechanics analysis. The Corvis is a high-speed, ultra-high-speed Scheimpflug imaging that takes in 31 milliseconds, 140 frames. And this will document how the cornea deforms due to the air puff for corneal measurements with non-contact tonometry. This can be analyzed in terms of graphs in the Vinci-Guerra screen report, and also with the CBI, the corneal biomechanical index from the Corvis, which is very nice work that we collaborated with Paolo and Ricardo Vinci-Guerra. And this data can analyze if the cornea is soft, if the cornea is less soft, based on the deformation of the cornea, and these parameters can be summarized in the CBI. Interestingly, we combine tomography and biomechanics using artificial intelligence, and this is the seminal study from 2017, in which we have one eye randomly selected from 480 cases and for 204 keratoconic cases. Though those is one eye per patient, and we have also 94 cases with normal topography, in which the fellow eye had a clinical diagnosis of keratoconus. 72 non-operated eyes also were included, and you can have the TBI, a very nice sensitivity for detecting the abnormalities in up to 90% of these cases with a cutoff that was optimized to 0.3. Interestingly, we have cases like this one with a normal topography 2015, relatively normal tomography. The bad D is 1.35, is still not very abnormal, but the CBI is very abnormal. The Pentacam random forest and the TBI could be, and this interestingly, the PRFI is not abnormal in this case. So we have some interestingly situations on this, but the TBI can detect that the patient has a mild keratoconus, a form fruus keratoconus in the normal topography eye, while you had a mild keratoconus in the fellow eye. Still with 2025, this is correct visual acuity. Ectasia can occur unilaterally. This is an important concept. This is a case that presented for unilateral ectasia, did very well with the corneal ring. Uncorrected vision was better than 20/20 in the left eye, and this patient is still stable for more than about now 10 years, I would say. And this patient had a follow-up with Dan Reinstein in London, who was very prolific in the epithelial thickness analysis with Orbscan score from Corneal and Saad, all normal. And this patient had also a normal corneal tomography and biomechanical index close to 0. So this is a true unilateral ectasia, and this patient admitted that he rubbed the right eye but not the left eye. And this stability is documented just before the pandemic time. Interestingly, keratoconus is a bilateral disease. True unilateral keratoconus does not exist, but secondary ectasia can be related to a pure biomechanical process. This is a very nice study from Japan. 3 ladies, 3 daughters of a patient with moderate to severe keratoconus, all of them with 20/20 or better distance-corrected vision, and many abnormalities detected on tomography and biomechanics. So this is genetics. Another case that we published with identical twins. Interestingly, the TBI is abnormal in all the 4 eyes, and a genetic study will identify some moderate risk due to some genetic factors that were identified for ocular surface inflammation and eventually some weak biomechanical structure of the collagen. So this is something that we will see more and more in the future, looking at multimodal integration of imaging and structural data and genetics and molecular biology. This will be related to LOX, the lysyl oxidase, which is a very nice work from colleagues from India, from Bangalore, led by Professor Jorge Shetty. And I will give you an example. This example of a patient 13 years old. The left eye had a mild keratoconus with 20/60 distance-corrected vision. The right eye is very normal. He has 2 scales. The right eye can be improved in the terms of the diagnosis. If you look at tomography and biomechanics, you see the TBI of 0.43. So not only age, we confirm the fruit disease in the right eye. But what about the left eye? You see very weak cornea. The stiffness parameter described by Cynthia Roberts is very weak, and this patient has a prognosis of progression. And I usually don't indicate surgery the first visit, but this patient I advise for doing cross-linking. This patient decided not to do it and came back in 6 months. And interesting, you see Kmax interestingly reduced, but you see a little more red here than here. And the subtraction map from the more recent exam and the previous exam, you see this is steepening, which correlates perfectly well with the Bellin, ABC, eventually also the D. The patient also lost vision. So when you need surgery, you should do it as soon as possible, because you are losing opportunity if you don't do it. And interestingly, this patient was guided to have procedure. We have to think about what we don't know. We don't know what we don't know. And eventually this quote from Neil deGrasse Tyson is very important, because sometimes you know a little bit to think we are right, but not enough to know we are wrong. And we have biomechanical diagnosis of the cornea nicely summarized in the early 2020 by my colleague and fellow PhD fellow Luigi Pellegrino. This looked at the literature, and we see some very, very much lower sensitivities for detecting the mild eye with a patient with asymmetric keratoconus. This was an opportunity to improve, is a revolution in evolution in terms of artificial intelligence, and we had a much larger population, expanding the number of very symmetric keratoconus for more than 5 times. And these cases are nicely summarized here in terms of the BAD-D, which is very good for detecting the clinical ectasia with 99% of specificity, up to 97% of sensitivity. You can reduce here and eventually get much higher optimization. But the cutoff of 1.27, which gives you bad specificity, I would say not acceptable, would not detect more than 70% of cases. So this is an opportunity that we can have for optimization, looking at the machine learning algorithms. And this was done in the TBI, which is also random forest number 2. This is the function number 4 here, you improve the sensitivity and the specificity considering the pink cases here, which is the very asymmetric ectasia cases with a normal topography eye. You see the correlation here, and I'll just close with a very interesting case, a patient 23 years old, no family history of keratoconus, mild correction. He presented for surface ablation as a candidate for laser vision correction. Colleagues from Iran are preparing this for publication. And this is very interesting because corneal topography was objectively normal, and even corneal tomography with the orb scan using Gattinel-Saad score analyzer. But when I saw the Pentacam and I was in a live session with them, I said, you know, based on the bad D, that is a kind of yellow, even the correction was not high. You see this elevation here, I would say, let's wait a little bit for doing surgery in this patient. That's my advice. And I would preferably look at the corvis and also data from epithelium. The patient had PRK and the patient developed ectasia in both eyes. Interestingly, they had a corvis analysis, and the corvis analysis, the first generation corvis, TBI and Pentacam integration was 0.49 and 0.5, and the TBI V2 was close to 1 in both eyes. So we were really able to identify in the pattern. And when you see this scale here, this is the Ambrosio 2 scale on curvature, is an absolute scale with a palette that goes from dark blue to pink, almost pink-white. This is something that you can see some abnormalities here. And if you change the scale for a more sensitive scale, it will definitely light out the abnormality. But this patient is a mild case and was detected as keratoconus in both eyes based on the tomography and biomechanical integration. This is a true revolution in evolution. We need to understand what we are trying to achieve in terms of the diagnostics that starts from anamnesis, a slit lamp, up to the most complex imaging with OCT, Scheimpflug, etc., and also with genetics, molecular biology. This is multimodal refractive imaging, and I thank you very much for your kind attention. Thank you very much for the opportunity, and I wish you all the best for this meeting, and I look forward to collaborating with you in the near future. Thank you.